Good afternoon, everyone, and welcome to the Independent Sage briefing, the last of 2022. And as we approach the end of the year, there is a reminder to all of us that we need to be careful and mindful of our own and other people's safety. Keeping that in mind, we have come up with a little guide for navigating this festive period. Although we are aware that this period is not particularly festive for many people, I was very struck this morning listening to Radio 4 of a full-time nurse who, on the radio, the full-time nurse who was extremely embarrassed because she'd had to visit a food bank because of the inflation and cost of energy that meant she couldn't feed her children. So for many people in the country this year, they're having a very hard time. So Professor Stephen Reicher will present the end of year statement, and others in the panel will also give their insights before we move on to questions from the public. But before we get to the end of our year message and our questions, we have our sage at the stats, our teacher about trends, our numbers nerd, Professor Christina Pargle. Christina.
Okay, wow. Thank you for that introduction, Anthony. Right, let me share my screen. Right, here we go. Okay. So today I'm going to cover vaccinations, prevalence, deaths, hospitals, and NHS strain. I'm going to show a few more charts than normal just because it's the end of the year, kind of wrap up where we are as we head into the Christmas period. So vaccinations. I just want to show this chart. This is the daily vaccine doses given in England since the beginning. And I just wanted to show it because you can see we're doing hardly anything at the moment. This is the main rollout in the first 3 quarters of 2021. This was the really accelerated booster rollout a year ago when Omicron arrived, and we really pushed, and we were almost doing 1 million vaccinations a day. This was the spring 75 and over booster, and this was the autumn 50 and over booster. And you can see now there's really nothing happening, but we haven't actually finished this booster rollout. So this is where we are. This is all the nations. This is over 65. So for over 65s, it's not bad. It's over 80% everywhere and over 90% in Scotland, although it could still be better. But for the 50 to 64-year-olds, I mean, it's really quite a disappointing uptake. It's between 50 and 60% in each nation. And as you can see, we're really not doing anything anymore. And just to go back to this graph, really, everyone under the age of 50, all adults on the age of 50, were mostly vaccinated a year ago. So it's been a long time since the rest of us have had a vaccine dose. And it's certainly not the case that everybody else has at least 2 or 3 doses. You can see there's still significant numbers of young adults who haven't had any vaccine doses, and and still quite disappointing uptake in children. And that, again, there are very few vaccinations happening now in children. So let's have a look at prevalence and see how much COVID there is around. This is the latest ONS infection survey data. And now you can see this is the latest figures here from the 5th of December, and it's going up in all nations now. So I think it's fair to say, remember, this is lagged by a couple of weeks. It's fair to say that we're now definitely in a new wave. If we look at regions of England, it's going up everywhere. It's actually highest at the moment in the London, the east of England. And you can see that things have really increased a lot in that first week in December in London, the east of England, and also the northwest and southwest. I don't know why that would be so much higher, so much of a bigger increase than the Midlands say, but I wanted to let you know. And in terms of ages, we're seeing the biggest increase in adults between 25 and 49. And I just wanted to kind of give you an update on where we are with variants. This is just this year. So this is all Omicron. You can see how Omicron subvariants have progressively taken over from their parents and grandparents. We had quite a long run of BA5 from July up until about a month ago. Now BQ.1 and particularly BQ1.1 are dominant, but there is a new variant that is increasing. It's called CH.1.1. It's only about 10% of cases, but it is still growing, and it is 10%. So we'll see what happens to that over the next few weeks. And I just wanted to highlight this. This is quite interesting. So the ONS Infection Survey started a pilot where, as well as testing for COVID, they're testing the samples for flu and RSV. They're only testing a really small number of the people they normally test for COVID. So the confidence intervals are much bigger. So it's much less certain estimates. But I think it's a really good idea. I hope they continue it and roll it out to the rest of the program. So this is just showing you the data that they have so far. It started in October this year. This is COVID, this red line. So you can see it coming down and going up over the last few weeks. This black line is RSV and this blue line is flu. And you can see these bars. I mean, it's really is quite uncertain, but you can see the increase in RSV over the last few weeks. And the flu trajectory is much less certain. But I think if this continues, we'll see RSV hopefully dropping and flu continuing to go up. And you'll see that in the hospital data in a minute. But I just wanted to highlight that they're doing this. I think it's a great idea. Just a quick update on deaths since it's the end of the year. This is, again, COVID on the death certificate, so not incidental deaths up to 2nd of December. Basically, it's still coming down, which is expected because it's obviously 3 to 4 weeks after an infection. As this wave continues, we'll probably see this start to go up again. Hopefully, the autumn booster will mean it will be relatively, well, hopefully it will not get to this peak that we saw in October. Right, hospital data. This is the number of people in hospital with COVID per million people for each UK nation. You can see the numbers are definitely going up now in England and Scotland. Harder to tell in Northern Ireland and Wales, because they're a week behind in terms of their data. But we also saw in the ONS Infection Survey, Wales has started increasing now, and it looks like Northern Ireland might be. So we should probably see this going up as well over the coming weeks. In admissions in England, you can see we are definitely in another wave. Both admissions with COVID and admissions for COVID are increasing. So it's not just about incidental admissions, but also remember, even an incidental admission isn't meaningless. For a start, a lot of it is in hospital transmission with people who already sick with something else. That's not ideal. And it also means it just makes it harder to control spread within hospitals. The more people have it, including spread to staff. And when it comes to admissions, most of it is the over 65s. So you can see that here. Which is a little concerning. And I just wanted to highlight this because this pattern looks a bit different to the ONS pattern in terms of where things are going up. And really over the last week, we saw a really big increase in the Southwest. I mean, it's increasing in all regions, but a really big increase there. And it does seem to be there. It's not kind of small numbers or anything, but I don't quite know what is behind that. But again, something to keep an eye on. The good news is that it looks like RSV and rhinovirus are now on the down. So they're going down. So that is good. We had this big rhinovirus, that's kind of a cold thing a few weeks ago. That's now coming down. And RSV, which was causing a lot of hospitalizations in the very elderly and young children, is also coming down now, which is good. However, flu is increasing, and it's increasing quite rapidly in all age groups. This is UK HSA data. And we're now seeing that the admission rate to hospital with flu has just this week overtaken the admission rate from COVID, although both are going up. But you can see there's been hardly any flu all year, but we're definitely now in a flu season. And so far, again, this is comparing it to previous years. So this is 2019-20. This is 2018-2019. There wasn't really any flu for the 2 previous COVID years. But you can see we're going up steeply and we're already higher than we were in 2019. So it looks like it could be a doozy of a flu season, which is bad news for the NHS. But please, if you're eligible, please get your booster, your flu vaccine. Right, so I just kind of want to finish talking a little bit about the current NHS strain as we go into winter. This is the percentage of ambulance handovers at hospitals that take longer than an hour. So the target is 15 minutes. And obviously, the longer it takes to hand over a patient from an ambulance crew to hospital, it's worse for the patient, but it's also worse for the ambulance crew because they can't go and pick up new patients. These are previous years. The dotted lines are pre-pandemic. This orange line is 2020-21. So this is kind of the long lockdown we had that winter and the alpha spike here. This was last year where we had much higher weights than normal. And this is this year. So you can see we started off worse, we're staying worse, and we're getting worse, right? So, almost a fifth of handovers are taking longer than an hour this year. So that is really quite concerning. In terms of the number of critical care beds, so intensive care beds occupied, we're kind of running at the same level as we had pre-pandemic and also a year ago, which is good news. This was that really bad alpha wave in the winter of 2020, 2021. So that at the moment is not looking too bad, but we are now seeing really rapid increases in flu patients in hospital. And this is admissions to ICU for flu, which is the light blue line, and COVID, which is a dark blue line. And you can see flu's going up really rapidly, but COVID is going up too. So we're actually, at the moment, we've got two things that are increasing pressure on ICU. And the other thing that's impacting hospitals a lot is it's harder to discharge patients, and that's partly because social care is so overwhelmed at the moment. So we have many more patients in hospital for a long time compared to previous years, and that's just making it even more difficult to do everything that hospitals need to do. So to summarise, there's hardly any vaccination going on, and just over half of 50 to 64-year-olds have been boosted. Prevalence and hospital admissions suggest we're definitely in another wave. It's a bit, it is Christmas, so that is going to cause things to go a bit haywire, not just in terms of everyone mixing and meeting up, but also in terms of actually the data being slower to come out. And as well as COVID, flu admissions are increasing really rapidly. Other respiratory viruses are reducing, but I think we're in for a bad flu season. And the NHS strain is still severe. And with that, I will stop and hand over to Anthony and Steve.
Thanks very much, Christine. Can I just query one thing? Because the flu data you gave from the ONS seemed to show it's substantially lower than RSV and COVID, presumably because they test everyone. Whereas the hospital admissions put down to flu are now above COVID. Is that because a lot of stuff is being lumped into the flu box, that it could be a number of, because they don't test so much in hospitals for flu?
I don't think it's that. I think for a start, the admissions go up to about 10 days later than the ONS, right. And it has been a really recent increase. And secondly, it is quite small numbers. And so there are those really big intervals on the flu data. So I don't think you can read too much into that.
Okay. All right. Well, look, thanks very much. We're going to come back to a lot of interesting data there and concerns about the coming month. But I'm going to hand over to Professor Stephen Reicher, who's going to talk about an end-of-year message. Steve.
Hi. There should be a PowerPoint, if it can be put up. Perhaps it can't. I don't know.
Have it back.
Okay, good. So I'm afraid I can't compete with Christina for pullovers, but I do want to introduce our end of year statement for 2022. And as we've been hearing, I think it's very much a matter of getting the balance right and giving a balanced overall assessment. Because on the one hand, there is little doubt that things are better than they were at this time of year in 2020 and 2021. Going on to the next slide, if we can remember back to those times in 2020, the Alpha variant was causing huge damage, and we didn't yet have the protection of a vaccine. In 2021, we were seeing the beginnings of the Omicron variant. We saw in Christina's graphs just how high the infections were and how high the vaccinations were at that point. So compared to those 2 years, things are much better now. Infections are down and immunity is up. And for many people, perhaps for the first time in 3 years, people are looking forward to seeing family and friends over the festive season. But that's only one side of the story, because clearly, and it's a point that we try to stress, especially given the level of denialism that is going on, that things aren't over. And again, if we can go back to the PowerPoint and to the next slide, well, to this slide. First of all, by now, infections are well over 1 million. 1 in 50 in England means that there are over 1 million infections in England alone, and they're rising. The second thing is, and again, Christina pointed this out extremely clearly, that it's getting longer and longer since people had their last jab. And over time, immunity is waning. And overall, putting together the over 50s and the over 65s, less than 2/3 of people, only 63% of those eligible have had boosters. And new vaccinations, and again, Christina showed the figures very clearly, that are basically grinding to a halt. So the situation with immunity is getting worse. People are having less and less immunity. And never forget, of course, long COVID, the so-called pandemic in the pandemic, as the WHO has put it. Over 2 million people in this country have long COVID, and nearly 1 million have had it for over a year. And then, of course, we have those other health loads, flu, RSV, strep A. So the balance needs to be looked at overall. It's better than it was 2 years ago, better than it was a year ago, but it's certainly not all over. So back to the slides. What all this does, the remaining load of COVID and long COVID, is it puts a whole series of burdens on the economy. We have shortages due to COVID and people not returning to the workforce. And don't forget that the UK is the only rich country in the world where the numbers in the workforce are still below the pre-pandemic levels. It is a huge burden on the NHS, and we could go on about that for a long, long time, but we all know about it. And it's a particular burden, and we mustn't forget this. It's a particular burden on the 3.7 million people who are classified as clinically vulnerable, and on their families, and on their carers. For them, the prospect of people mixing without precautions, of leading to increased levels of infection and dangers of them getting infected, means that the situation is really very concerning. Nothing to celebrate, something to be very concerned about. So back to the PowerPoint. So what we're saying is very simple in a sense. It's something that was stressed at the beginning of the pandemic, that this was about looking out for each other. It wasn't just about looking after yourself. It wasn't only about personal responsibility. It was about social responsibility, about being kind to others, being considerate and being concerned about their fears and what your behavior might do to them, and therefore being careful. And therefore we've come up with a very simple 5-point plan to say what we should be doing to be kind, be considerate, and be careful. And that's on the next and final slide. And they're very simple things. And again, none of them will surprise you. The first is get vaccinated if you haven't already. Get a booster if you haven't already. And get a flu jab if you haven't done that already. Book a test today. If anybody watching hasn't done it yet, as soon as you stop watching, book that test. The second thing is, if you are ill, whether with COVID or anything else, don't go out and infect other people. Stay at home. The third, again, we've forgotten about testing. And sadly, testing is no longer free, and it will cost. And actually, given the cost of living crisis, some people won't be able to afford to do it. But if you can, please take a test before going out, especially if you're visiting elderly or vulnerable people. That's quite critical in terms of being considerate. The fourth, I won't do a Tony Blair and say ventilate. I just did, but do ventilate. When you're meeting up with people in your homes, make sure the ventilation is good. Ventilation makes a huge difference. And the final thing is, be very careful. For instance, when you're traveling to go and see people, it's no good ventilating when you get there if you sat on crowded public transport where you might have got infected. So if you are in a public space, a crowded, stuffy public place, such as public transport, please wear a mask. The point is that none of those things will undermine the pleasure you get and the joy of meeting up with others. But by being careful, we'll make sure that the celebrations in 2022 don't give way to commiserations in 2023. So I hope everybody does have a great end of year, a good, healthy and safe 2023, and does take account of those simple steps we all can take to be kind, to be considerate, and to be careful.
Steve, thank you very much. Excellent points. And I'd just like to throw some of these points about, staying safe. I know we've been over this many times before, but are there some questions that we might address? So, for example, getting tested, LFTs, how valuable are they? Are there false negatives and positives? And if they're going to cost money these days, and there's a lot of people in the workforce, should employers be paying for this? So a number of questions here. Let's kick off with Steve Griffin, because you're our kind of expert on tests and LFTs.
Thanks, Anthony. So there are a lot of rumours going around about tests. There's also a lot of people that are saying that they have symptoms consistent with COVID, and they say because they've done a lateral flow test that they don't have it. Now, whilst that's always encouraging in terms of the level of virus that's present in your respiratory tract, you can't confidently say that a negative lateral flow test is meaning that you're completely free of infection with SARS. It could be other things, but we need to remember these are what we call red light tests rather than a green light test. That's because the level of sensitivity of these things, because they're physically picking up the virus particles, bits of the virus particles that are in your airway, they're not as sensitive as something like PCR, which amplifies that signal and so is therefore very much more sensitive. So it could well be that you are infected and potentially infectious, because Omicron is so much more infectious than viruses that we saw previously that you can actually be infectious with that. But what a lateral flow test does tell you is that if you are positive, you are definitely positive. There are very, very, very few false positives in those tests. And if you see any kind of line, if you think about the number of virus particles that probably go towards making that line, as faint as it might be, that almost certainly means that you are able to pass that infection on. So what you often see is that you don't necessarily turn positive at the beginning of your illness, but you will be positive later on and stay positive for quite some time. And so this sort of idea that you'll be fine in 2 or 3 days is usually not correct, I'm afraid. So please use the tests as they're meant to be used, as a red light, not a green light.
Thanks, Steve. A question actually now to Sheena or Danny. Sorry, Professor Sheena Cruikshank and Professor Danny Altman. About, you've got lots of people going around saying, well, if it's so common now, you get infected, so you get a booster, and that might be why we're gradually seeing more dampening waves of this, and that eventually it will become like other coronaviruses. Is that a reasonable statement, or is there another side to this? Because I'm still fearful that in January, with all the right conditions, the next wave is going to be perhaps nearly as big as last January. We just don't know. Sheena, let's come to you first on that, and then Danny.
So I think it is a myth, this idea that it's necessarily going to evolve to be milder and unfortunately, particularly with Omicron, we aren't seeing a really robust long-term immunity. And it's not just the risks of being sick with COVID that we have to sort of think about. There's also the risks of long COVID. There's just been a really big study, actually, that's brought together lots of the studies. So this has brought together a study of approximately 1.2 million people. And they estimated that around 6% of people who have symptomatic infection get long COVID. Now, that varies depending on how severe the COVID is as well. So other studies have shown that your risk of getting long COVID does increase if you've had severe COVID, but even mild COVID can cause a risk of long COVID. And that can keep you out of the workforce, and very unfortunately for quite a long time. And it could also have economic consequences as well as making you feel absolutely dreadful. The other thing is that we are seeing growing evidence in the literature that even people who have had sort of an infection that they've got over with, they still have an increased risk of developing complications. And that particularly seems to be the case for around a year after infections. And again, studies have shown that that risk of things like cardiovascular disease seems to persist for about a year. So it is absolutely vital that we do get things like our boosters. We do try and keep our nearest and dearest safe, because it's not just an infection, it's the other consequences of that infection. And that's what really worries me, to be honest.
Thanks, Sheena. Danny, any thoughts? And I think Christina.
I'd only add a very small number of words to everything that Sheena said and Christina said and Stephen said, which is, my Christmas present to anybody would be go and please get your booster. And the reason is that, as you saw in the graphs that Christina showed, we're really stalled at that kind of 55% or so level, which means an awful lot of boosters not taken up. And whatever you might think about, I boosted myself with that Omicron infection I had 3 months ago, if you look at the hard data, it doesn't stack up. The people going into hospital and the people dying are the people who haven't had their boosters, and it's very rare to have that severe an outcome in boosted people. So, how much evidence do you need? Just get boosted.
Thank you. Christina, you were going to ask a question of Danny.
Yeah, I was. And it's about how to use the lateral flow tests. And I mean, I think testing is really important. And I wish we were doing what they're doing in the States, where the US government is sending out free tests to every household for the Christmas period. And I think that would be firstly, it's really useful, particularly when it can cost, upwards of £10 to test a family. And secondly, just as a message that COVID is still here. But my question is, there's this kind of idea that, after 5 days, you're no longer infectious, regardless of what your lateral flow test says. But that isn't true, is it, Danny?
I think we're in really, really hard times now, aren't we? Because it's harder to get hold of lateral flow tests. It feels harder to report lateral flow tests. And you're faced by this kind of wave of misinformation that says, yes, on average, you'll be better after 4 or 5 days. So you're duty bound to go back to work. And you're absolutely not. Yeah. So if you can gather up some lateral flow tests and do it every day or every couple of days, lots and lots and lots of people are still positive at 7 and 8 and 9 and 10 and 11 days. And therefore, as Steve was saying before, they're still infectious. And so every chance that they're going to spread it around their school, their workplace, their bus, whatever, why do it?
Yeah. Actually, Richard van Abendorf, who's going to ask a question in a moment, has just put in the chat saying, well, China, who are now opening up, are saying to their population that Omicron is much less dangerous. Do we agree? And just to add to that China, I'll come to you, Steve, in a minute, because I know you feel strongly about this. China has had an upsurge in their vaccination rate. They are now opening up. Their cases are rising steeply. And this morning, there were a lot of reports. It was actually made the headline on the Financial Times that there are thought to be quite steeply rising numbers of deaths, even though they haven't been officially reported. So we need to watch that very carefully. But Steve, your point is that Omicron is not mild.
Well, no. So there are two things that people get confused about with this. The first is that we know that the first set of Omicron variants, the BA1 and 2 that we saw sort of last Christmas, they shifted where they like to go in the lung. They preferred to go further up in the lung, in the nasal epithelium, which generally speaking meant that there were fewer hospitalizations when you had a breakthrough infection in a vaccinated person. Okay, so yes, it was less virulent than Delta in that sense. Now it's pretty clear that the majority of the viruses circulating are now going back down the lung. Okay, there's quite a lot of good evidence that's showing that. So things like BA5 that we saw in the summer has the propensity to give you the same sort of infection that Delta did, that Alpha did, and that the original virus from China did. Okay, so there's that aspect to it. But disease is always an outcome of your immunity and the virus. Okay, so as we saw in Hong Kong in spring, where there was very little immunity, where elderly people hadn't been vaccinated terribly well, BA2, which was one of the viruses that went to the upper part of your respiratory tract, caused a devastating wave there. So I think in this country, we've got a little bit complacent because we have a good level of coverage, at least to start off with relative to other countries. And that immunity is what protects us from that more severe disease. So of course, if you haven't had your booster, as Danny says, if you haven't had vaccines at all, then you are much more at risk of that tipping the wrong side of dangerous, I'm afraid. So don't take this virus as something that's attenuating or becoming weaker. It really is not. It's our immunity that's protecting us.
Helen, can I come to you, because you're in the front line? You wanted to say something, I think, about how to do LFTs, because there is this sort of, you've got to gag or shove it right up your nose. But do you want to tell us how to do a really good LFT?
Yeah, and this is quite important for me because I'm seeing lots and lots and lots of patients with viral symptoms, quite a lot with sore throats who are worried they've got streptococcal infection, which is a whole nother thing. So lots of my patients are coming to see me and they've got symptoms that could possibly be COVID. And they'll say, no, it isn't COVID, doctor, I've done a test. And I say, what did you actually do? Because depending on what symptoms you've got, there may be more or less virus actually in your nose, and there may not be very much there, or you may not pick up enough for your test to go positive. So a lot of the tests come with a little short stick in the packet and instructions to just swab your nose, but you won't pick up enough virus in lots of cases, even if you have got COVID, for that test to go positive. You do need to swab your throat, tickle your tonsils if you can. Some people suggest actually the saliva from around the gums is also very useful. You just want to get as much load of virus as you possibly can. So it definitely has to be from the mouth, from the throat if possible. You can add the nose too, but actually that's probably a less good place to harvest your virus from. And I know you're hoping you're going to get a negative test, but that doesn't mean it's helpful to only do a half test. So try and, if you can do it properly, which means doing the mouth as well as the nose, whatever it says on the box.
Are we a bit misled because of a respiratory? We think this is a respiratory infection, so we go for the nose and the throat. But actually, the pathologist, remember we had that expert pathologist on a couple of months ago, was it Richard somebody? And he gave a great talk, and he said the distribution is all about where the blood vessels go. And he thinks that it tracks down from your mouth and your gums through lymphatics rather than through the lungs. And that's a cause. And that this is basically a blood or blood vessel infection. So I'm just wondering whether actually the gums and mouth makes much more sense than shoving up your nose, or am I being amateurish and naive? No, I'm not amateurish and naive, obviously. So any comments on that? Steve, and then Susan had her hands up, and then perhaps we'll go to the questions.
Yeah, I mean, the answer is, as Helen says, it's not about just doing one, it's about doing all of them well.
Yeah.
The other thing is that when you're doing your nose, don't just go up, because your nasal cavity is actually sort of behind here, your sinus is going, so you almost need to go in and go round that way. And that's why those longer swabs were much better. But no, the virus, when it goes into you, is doing one thing, but when it's coming out of you, it does go in all parts of your upper respiratory tract. So it's mainly going to be around the tonsils and at the back, as Helen rightly said, but there is some in the nose, but it's hit and miss. So you may as well, and it can go in different places in different people. So it's best to cover everything, is the idea.
Thanks, Steve. Susan, you had a comment.
Yeah, well, Thanks. A question. On the leaflet in the test box, it says, don't do the tests within 2 hours of eating or drinking. Is that important? Because people don't really know about that. And the other thing is, unfortunately, I know quite a few people, colleagues, neighbours, family and friends over the last, say, 2 weeks who've gone down with COVID. And so there's been quite a lot of chat about it, especially amongst some younger people I know. And so they've been coming up with things like, well, if it's a faint line, then I'm not very infectious, so I can go out. Another thing is, after 1 day of a negative test, then that's fine, I can go out. And another one was, well, maybe there's all this strep A around, so maybe if there's just a faint line, it might not be COVID anyway, because it might be one of all these other things. So there's about 4 questions I've thrown at whoever wants to answer.
Well, I'm going to get on to some of the longer term questions here in a moment, but any quick response to those that some of the points that Susan has raised? Steve? No? All right, well, look, I'm sure these will come back. Sorry, go ahead, Steve.
I think Sheena should be probably the best.
Oh, Sheena, sorry.
The ones that Susan's raised.
Yeah.
She's raised. So the tests are specific to SARS-CoV-2. They've got specific antigens, specific bits, features that they're looking for and they're binding to in SARS-CoV-2. And it's absolutely critical that you do the test correctly or you will have a false negative result. I know that my poor dad did them wrongly and had a negative result and got us to come down and stay with him. And he started coughing and I made him do it again under supervision and he was actually positive, which was a little bit disappointing as we'd gone to stay with him to look after him. In terms of eating, I think it's about how much viral load you've got for one. So early in the morning, you're likely to have quite good viral load. But the other aspect is some foods can interfere with the test and give you a false positive. And of course, there was a little spate of this happening with school children who were using very acidic substances to interfere with their test result. But if you've got any kind of a line, that means you're secreting out lots of viruses. And it only takes one virus from one nostril, from one droplet to infect another person. So yeah, unfortunately, a faint line or a thick line still means that you're infectious. I think I've answered all of those.
Lovely. Thank you. That's brilliant, Sheena. Okay, I'm going to go. Well, first of all, I'm going to say, if you want the Christmas message and those key points, it's going to be on our website, so you can download that if you forget those key bullets. But I'm going to ask Richard von Abendorf, who's the first of our invited guests to come and ask a question. Richard, what's your question?
Thank you. Greetings from freezing Lewisham in southeast London. As Sheena said, I've read reports of excess deaths of men aged 25 to 50 due to cardiovascular and respiratory conditions are nearly twice as high as first documented. My 3 quick questions that emerge from that is it true? And maybe more meaningfully for some people, how much more risky do we think it is than smoking or drinking for this age group? Number 2, how do we manage it as we allow COVID to spread? Some have suggested, routine cardiac surveillance. And finally, as a small minority in a way, trying to carry out these safety measures, and we tell people we do it to prevent spread and infection of acute COVID, and as someone said, that second pandemic, avoiding long COVID, should we call this a new risk? Should we call it post-COVID cardiovascular syndrome causing heart attacks and strokes? That may shake some people up. Or is it all too late? But not being facetious here, is it a new dimension to the risk of COVID, or is it really being looked at under the long COVID umbrella?
Richard, thank you. That's an incredibly important question coming from someone from where I was born in Lewisham, and brought up. No, so it's all about cardiovascular risk in young people. It's about how we might be screening for that. And is this actually a new syndrome? Do we need to start carving up long COVID diagnostic categories and particularly emphasizing the cardiovascular risks. And, my wife had a myocardial infarction as a result of COVID. So I know about this a bit. But who should we go to first on this? Danny, perhaps because of the whole long COVID expertise that you have. I might come to Helen as well.
Yeah, let me try and give you a sort of balanced answer to this, because we're all trying to kind of strike that balance, aren't we, between totally spooking ourselves so that we daren't leave the house, and on the other hand, just having a solid awareness of the risks. It's true, this continues to be a very difficult infection. So I remember when we were first learning about it in those first few months, when we had few cases here, and the Italian health minister was being interviewed by Andrew Marr, and with that way that people have sometimes where if English is their second language, they use the vocab much better than we do. He said this is a very mendacious virus. And I thought, what a brilliant word, because it does crazy things that no coronavirus ought to do. And it's, on the one hand, that's true. Yet the particular question of cardiac effects and myocarditis, I know that if we had a panel of cardiologists on today, there wouldn't be strong consensus between them, because there are some studies showing it's really there, and some saying that at a sort of, at a powered level, it's not. We do know from all the long COVID literature and the imaging of long COVID that if you take a bunch of people who've got long COVID symptoms and image different organs in their body, you'll see end organ damage in lots of different places. And the way that I spooked myself this week was this paper that came out in Nature this week, which admittedly is post-mortem autopsies on people, most of whom, but not all of whom, died of COVID, but not necessarily. Some of them died a long time afterwards of other things. And they had virus and damage all over their bodies. So I feel like I haven't given a very clear answer, given some scary news and some non-scary news, but there's a lot of stuff going on. I'll stop there.
Danny, I thought that the cardiovascular stuff, because again, we had the excellent person on from Cambridge who talked about that. And there's been a huge study showing that in the first month after COVID, there's 21 times the risk of cardiovascular outcomes, and that the risk declines over the year. But even by the 12 months afterwards, and this was mild COVID, the risk was about 20% higher. And I'm trying to remember that the paper.
Well, you're talking about the Nature Medicine paper, which is a very, very large, compelling data set from the US Veteran Affairs study,
That's right.
Which is huge and compelling and hard to argue with. So yes, there's an effect. I mean, there's undoubtedly an effect. I suppose what I was bringing in, just to muddy the waters, is where people have done imaging studies on panels of people who are seropositive and recovering from their COVID. They didn't see anything as explicit as that, but that's a much smaller sample size.
Yeah. Is that a hand up, Zubaida? No, I'm sorry. Sheena. Oh, and then Helen. Sorry.
So in terms of the links with COVID, I think there's all sorts of things going on. So one thing is thinking about the virus itself, and if there's a persistence of viral reservoir in places that causes like a constant little provocation of your immune response. The other aspect is thinking about what the immune response has done in of itself and how much damage that has done, and whether that has occurred in different organs, which is kind of what Danny's just been terrifying himself with. And don't forget that a lot of people who were already more vulnerable to COVID in the first place already had issues with cardiovascular conditions or cardiovascular related conditions, such as diabetes or other conditions that will affect both their immune system functioning, but also affect their susceptibility. So I think what it shows you is that, like all of these conditions, and the more and more we understand, is that your immune response to any one thing and the way you deal with a virus is multifactorial and it's individual. And so it's very difficult for us to understand the kind of simple risks of different individuals and different things that the immune response is going to do. But I do think it's something that we do need to monitor. long term, because we do need to understand. But the latest studies do suggest that the risk does seem to drop after about a year. So you seem to be going back to a better baseline by at least a year, and probably a bit less.
Okay, Richard's point also is about public messaging. I'm going to go to Helen, then Steve Reicher, and then I might move on, Steve Griffin, unless you do a very quick comment, because there's lots of questions. Helen.
I was only going to say it is really complicated. We definitely have seen an increase in cardiovascular morbidity. So that's people having poorly hearts. That's happened since the COVID began. And some of that, I'm sure, is to do with COVID and to do with long COVID. Some of it may also be to do with precisely those people that Sheena was talking about who've got cardiac risk factors actually not getting the routine care that they needed through the pandemic. So that probably made a little bit of difference, that people's blood pressure may have been less well controlled because they weren't seeing their doctors. So it's actually quite difficult to tease it out. I don't think that's the whole explanation, but there's probably some of that in there too.
But Steve Reicher, should we be targeting younger people, as Richard suggests, saying, if you're running a marathon, you should get tested. There is an increased risk. You've got to be careful. If there's any sign of infection at all, you shouldn't go out and play Sunday morning football or things like that. I think that's the point he was making. Steve.
So I want to take up his point and also Danny's point about that balance between making people scared and being realistic. In the end, actually, making people scared is counterproductive. If you just tell people, you're doomed, they tend to put their head in the sand. Doesn't help. If you tell people there is a risk and this is what you can do to mitigate it, then they will listen. So the two need to go together. You need to give the information, but you also need to give the means to do something about it. And that takes me back to something that Christina said, that by far and away, the most powerful message we could give would be to send free LFT tests to all households, exactly as they're doing in the United States, because that would be a message about risk, but it would be a means of doing something about it at the same time. It would be the two together, and it's that works. You need to empower people to keep themselves safe, not make them afraid.
Okay, thanks. Steve, did you want to add anything? Steve Griffin?
Oh, well, just really quickly, yes, there are some nuances to COVID. There does seem to be a lot of vasculature involvement and things like that, and increased clotting risk. There's also all the things people have said. But it's not the first time that we've seen this sort of thing associated with big waves of viruses. So the Spanish flu back in 1918, 1919, there was thereafter, although records are obviously not quite as well kept as they are nowadays, there was excess deaths associated with some cardiovascular issues for about a decade afterwards, actually. So, I think that's partly what we're seeing at the moment, that kind of secondary issues of excess mortality that may be associated with just a huge number of infections. So reinfection is not a good thing.
Okay, we must move on. I'm going to move to Elizabeth Pear, if I've got that correct, or is it Pare, who is our guest and has a question. Elizabeth, are you with us?
Yes, hi. I'm zooming in from Ontario, Canada.
Oh, wow.
I wanted to thank the whole group for their clear scientific answers during these difficult times. So my question is, I'm looking into buying a far UV light that I may bring to my family dinners at my house and when we visit. Is this something that you would consider? And if so, why or why not? Also, I'm eager for any suggestions of how to make family dinners with my older parents safer once we take the masks off to eat. And no, we already use HEPAs and open windows.
Wow, that's a really good question. Elizabeth, if I may, I'm going to add in another question sent in to us, which is very linked, if you like, to this, from Sally O, who says, I'm visiting family this weekend, want to bring a portable air purifier to help protect against COVID. Is there any guidance on where the best place to put it is? And will it protect me against COVID whilst I'm at dinner unmasked? So anyone want to talk about UV lights or air purifiers? Christina.
So, I'm not an expert on UV light, but I would be cautious because it's still, we know that it can work, but it can also damage the skin. So at the moment when it's used in really big rooms right up in the ceiling. There is stuff around using a different wavelength, which is less harmful, but that's still really early stages. So I would just be careful about doing that. I think if you're using HEPA and open windows and testing, then that's probably like a really good thing to do. So that's just what I would say. We are going to have a whole session on airborne stuff and things you can do in January 20th, but I would just be careful, is my advice.
And I think air purifiers are nonsense, aren't they? Is there any evidence they work? I might be talking.
Well, if it's a HEPA filter, that works.
Yeah.
Oh, right. Sorry. Yeah, but that's a different, it depends what air purifier you're talking about, I guess.
Yeah.
Susan.
I mean, people use different words for different things, but the HEPA filters, i.e. machines that are taking tiny particulates out of the air, which can be pollen, viruses, dust, etc., have been shown to be really effective in terms of reducing COVID transmission. There was an excellent study done in Addenbrooke's Hospital in Cambridge, where they tried it out in different wards, having it or not having it, and collected data on it. And that's been replicated in other situations. So I think HEPA filters definitely are a good idea. And they do cost, I think, I don't know about the portable ones, which obviously just is the air around you, but for reasonably sized rooms, I think they're kind of £100 to £200, something like that. But always a good idea to read reviews of anything you're going to buy, so that you can be sure that it is doing the job that you want it to do.
So I think, Elizabeth, if you're going to be testing before your elderly parents come, and you're ventilating and you've got a HEPA filter, I think you're going to be pretty safe. Nobody's ever 100%, but you could rest assured, I think.
Thank you.
Thanks very much. And I hope it's not too cold in Ontario. We've got some other questions here. Just a number asked, I heard that there's discussions recently about FFP2 masks being given to staff during this winter in the health service. Is this something which is to apply to patients, or is it just for high-risk patients and wards and particular trusts? Would it not be best to raise this with the executive to reduce pressures? Does anyone know about current policies on FFP2 masks in health facilities, hospitals? I was looking at Helen, but she's shaking it. Yeah, Helen.
If it is, it hasn't come anywhere near general practice yet. I haven't heard any changes in the rules or the guidance yet. Absolutely, it would be sensible for both staff and patients to be wearing good quality masks in the healthcare setting. I think it's still somewhat in disarray after, one has to say, a rather over-optimistic abandonment of masks earlier in the year.
I agree. I think it's Zubaida.
Well, sort of related to that and related to some of the points that we've been making. Sorry, I've got some teenagers in the background here. It's the fact that, first of all, risks are not uniform for everybody. As we've already mentioned in our statement, there are clinically extremely vulnerable people around, but also exposure is not uniform for everybody. We know, and we've said this before, that Black and ethnic minority groups, people living in deprived areas, people living in overcrowded housing, they're all much more vulnerable, much more exposed to the virus than other groups. And it goes back to the point, we're talking about good quality masks, but good quality masks costs. FFP2 masks costs. HEPA filters cost. And I know you're absolutely right, Susan, it's not a huge amount, but it's still quite a lot in the cost during a cost of living crisis. So I want to go back to this point that right now, the government should be providing free tests. Right now, employers need to be much more active about the ventilation, that if you can't open windows, also have HEPA filters. Employers have duties here too. And that goes back to the fact that, once again, it's not just about and it's a lot, we've got nearly 4 million people who are clinically extremely vulnerable, but we've also got a lot of people who are much more at risk or at higher risk, because we're not all in the same boat.
Thanks, Zubaida. Quick comment from Christina.
Yeah, so just on the FFP2 masks, I think it would be really good if they were given free to hospital and care home staff. I can say that my dad has been between different hospitals and care homes for the last 8 weeks, and I have never seen a single member of staff in an FFP2. It's always the surgical masks. And in fact, as of this week, even care homes, they don't need to wear them, which is just makes no sense to me at all. We saw what happened in hospitals when they removed the masks. So I think it would be good. I'm not seeing any sign of it.
I find this completely staggering. I mean, not just for COVID, for flu, for RSV, for all kinds of things. Hospitals contain very high-risk people. It's the absolute basics of infection control that in those circumstances you should wear masks, but we seem to have an allergy to this. It's anyway, don't get me on that. Right, I'm going to take another question because it's quite a good one and important. So Anne McConway wrote in and said, can you talk about the immunity theft theory to explain children's apparent increased susceptibility to other viruses infections, please? And a link to that, are we seeing a new variant causing the deaths? I assume she means the few number of children's deaths. Is it increased susceptibility due to immune system damage? Is it co-infection with COVID? Are they treating it effectively with antibiotics if it is actually being driven by COVID? Mixed up there, whether she's referring to strep A or not. But any thoughts about the immunity theft theory? Presumably that's the immunity debt theory. Danny or Steve or Sheena? Sheena.
Let Sheena go first.
Yeah.
Sorry, I was struggling to find my mute because I thought you were about to do it. And this idea of immunity debt is a little bit of a worrying one. It's not a sort of immunological term used by immunologists at all. So it's a brand new term that appeared in probably just a Twitter feed or something about a year ago, and it literally has come from nowhere. What we're seeing is a combination of a lot of different things happening. There often are a lot of respiratory viruses at this time of year, and that causes people to get ill. And we are just seeing, unfortunately, just a kind of collision of those all at once. It's not true to say that these were not around in the previous years, because I remember taking questions over the last 2 years when we came out of various lockdowns. We went back and everybody said, oh, there's a super bug going around. It's super cold. We're all getting really, really ill. And it's the respiratory season. What you might be seeing, though, is that kind of like shift in peak incidence. So we talk about when people get those and the fact that some people might have been exposed to them a little earlier and they're getting exposed to them now. So it's a sort of shift in when they get exposed. And the idea that there's definitely so your immune system is just on a muscle, so it doesn't need that constant revision from having lots and lots of diseases to make it work properly. In terms of, is the virus and all these infections damaging our immune system? Well, some viruses and some infections can do that. The evidence for COVID is quite limited and quite mixed. There are studies that are showing that it can cause some sort of transient damage to the immune response, but that's often in people that have had quite severe COVID. So a lot of the studies that have come out are either very small groups or very select people, or they're looking at still what we call acute infections. So still 4 weeks post your original infection, and your immune system's just not settled down yet. It's not come back to its normal parameters. Probably true of any infection.
Thanks, Steve Griffin. You had a hand up at one stage, did you?
Yeah, sure. Well, yeah, I completely agree with what Sheena's saying. And the problem is that when people are talking about this immune debt, they actually mean different things, which I'm sure is incredibly confusing for people. For me, what they are doing is confusing two things. One is this idea of, it's an epidemiological term, really. So if you have seasonal waves every year, but then you miss a few of those, it means that younger people in particular won't have seen that virus. And so you have more people that are going to catch it in the year it comes back. Okay, so there is what we might call an immunity gap. Okay, it just means more people are getting it. So what you should do about that is vaccinate more or prepare more or take extra measures to prevent those infections hitting people. That has not been done. Okay, but the second thing is exactly as Sheena said, that people think that we're not training our immune system, and this is some weird twist on what's called the hygiene hypothesis, which has been widely debunked across decades. So actually what environmental bugs tell us is what not to respond to. It's something to do with something called tolerance. So there's this confusion when people are talking about this as well. But the major problem that we do have is that we are seeing these larger waves. Flu has come back in a big way this year. And we know that flu and things like chickenpox can make you more vulnerable to having a more severe bug infection. So there might be an element of that going on. But I guess you have to ask the question, why didn't we push loads of flu vaccines sooner? Why didn't we try and take more precautions in schools? I think that blaming this on restrictions that happened 2 years ago is a nonsense. And I'll finish there.
Thanks very much, Steve. All time for today. Special thanks to Steve Reicher for preparing the statement on our website, to all the panel members for their contributions today and throughout the year. Special thanks to Manasa Narayanan, who helps us prepare all of our sessions and does a fantastic job, tips and advice and all the rest of it. As I mentioned before, this is our last session before we break for Christmas. We will be back in the new year. The next meeting is planned for, I think, January the 13th. And it's going to be an important one because I'm uncertain about where this next wave is going. And if all the conditions are right for COVID spread and this thing hasn't died down, it could be a bad month for us, but we just don't know. So do join us again. Whatever religion you are, have a wonderful festive season. Celebrate it in the way that you think fit, and do stay safe. I've forgotten Steve's 3 words. What is it? Be considerate, be lovely, and be careful. Not be lovely.
Kind, be kind.
Be kind. That's really important. Be kind and be careful. So have a great time.
And people are.
Bye.
Bye. Namaste.
Happy holidays.
Bye.
Bye.